initiatives. Our first speaker today is Tracy Carafeno. Tracy Carafeno is our clinical program director for our inpatient operations in Smilow. She has been an oncology nurse for over 30 years at Yale New Haven Hospital. She is passionately committed to the patient experience, and as I said, currently serves as the clinical program director for our inpatient service. Our second speaker is Lisa Barbarata. Lisa has spent her nursing career in oncology the last 10 years at Yale New Haven Hospital in Smilow. She worked as an oncology clinical nurse specialist, an APRN in the Smilow hematology program, and a patient education specialist. She's now our program manager for oncology nursing education and practice. Please welcome the two of them. Thank you.
Good afternoon, everyone. I thank you for this opportunity to share a project that has significant implications for Smilow that I was honored to lead, which was looking at our 30-day readmission in Smilow. Whoops. So reducing readmissions is critical for many reasons. One, cost, and there's some studies that estimate up to $15 billion a year for Medicare patients who potentially 1 in 5 of get readmitted, which is the readmission for this criteria. Medicare is 30 days, within 30 days. And also primarily because of the patients. It has a huge impact on the patient, potential for infections, complications, and just overall being hospitalized more than necessary. So in looking at Smilow readmissions, on this graph you can see that Yale New Haven Hospital is the gold graph, which shows approximately around 14% is the hospital-wide readmission rate, and the blue and purple are Smilow 14 and 15, the surgical onc unit and the GYN onc unit, which are close to the hospital mean, around 14 to 15%. Then you can see the green and red at which is NP 11 and 12, which are around 34% average for readmissions, which is why we chose to focus primarily solely on NP 11 and 12 and excluded NP 14 and 15 from the data collection. This breaks down by section of hematology and med-onc since September of 16 through August of 17. And we highlight here in April the ECC, the Extended Care Clinic that's on NP 12 opening, because we are hoping that that will have an impact on readmissions as many patients that go to the emergency room that are oncology patients end up getting admitted. We are hoping that in the ECC they are able to triage and discharge patients from there without admitting them. And you can see for June, July, and August there is a slight trend down in both services, so we will work hard to hope that that continues and with focused efforts gets better. So the population, again, we looked at was NP 11 and 12, and we had a total of 53 patients in the study group between September of 2016 and December of 2016. The patients were seen on their readmission visit and were interviewed in their room by one of the nursing leaders that was involved in this study. 43% completed an interview, so the data collection consisted of a chart review and a patient interview because we were really looking to get the patient perspective on their readmission and what they felt could have done to prevent it. 43% completed an interview, and the reasons for that were some of them were just too sick to actually want to go through the interview, and some we made multiple attempts to visit, but they were off at tests or had just received bad news, so they did not want to participate. So overall, we had a 43% completion rate for the interview. When looking, and again, this was a sample during a period of time, when looking at the diagnosis of the patients in our study, the top 3 were lung, acute leukemia and MDS, and lymphoma of the patients that happened to be during this time period. And one thing that was interesting is the diagnosis. So the most common admitting diagnosis for this group was neutropenic fever and respiratory. Respiratory related include shortness of breath, a cough, COPD, or dyspnea. And the most common diagnoses on their second admission were the same diagnoses, neutropenic fever and respiratory related, although they weren't necessarily the same patients with the same diagnosis. So then we looked at the breakdown of readmissions, and when looking at the number of readmissions, 68% of the 53 patients were readmitted greater than 3 times, and 45% were readmitted within 7 days. The bottom graph shows the spread of admissions, and as you can see, some of the patients, 9 were admitted 5 times, and this is again during a 6-month period, and some being admitted as many as 7 times. In looking at the patients who died during the study period, 42% of the patients died, or 22 of the patients. And so we looked at the diagnoses of those patients that died, and here it shows that lung, head and neck, lymphoma, and the leukemia, MDS, were the top drivers of the patients who died. And then we broke it down as location of death, and this is relevant on many fronts, but 27% of the patients who died, of the 22, died in the ICU. However, good news is that 50% of the patients died under hospice care. It was either virtual hospice or other hospices in the community. And so that, I think, is a marked improvement and speaks to some of the work of regional and of having the virtual beds inpatient, although 27% in the ICU is an area that we would need to focus on. So again, trying to better understand those patients, we broke it down by heme and med-onc, and so 63% of the patients dying in the ICU were heme-onc, and 64% of where the med-onc patients died was hospice. And we started the regional virtual hospice beds on MP12 first, which could be partially how this rolled out, because in the patients who did not go to hospice, there were a couple on NP11 who did not want to enter hospice because they did not want to move off of NP11. So we now have those regional virtual beds on P11, so I think that will help as well. But clearly, more of the heme population dying in the ICU. We also looked at the Rothman index because it has been looked at in other studies, but in this group we found no correlation between their Rothman index and being predictive of being readmitted. And so most of the patients had a Rothman of 65 or greater. There was a sense from some of the physicians that many of the patients being readmitted were coming from nursing homes or short-term rehab. But in this group that we looked at, the majority came from home, either with no services or home with services. So there's an ability to focus our efforts on those patients. And then, so since the patients were going home, we looked at what was happening from when they left the hospital till when they were readmitted. And we found that they all had a follow-up, which was good news. All of the patients had a follow-up visit scheduled, and on average, it was scheduled within 10 days of their post-hospital discharge. However, on average, most of the patients were readmitted within 7 days, so a lot of them were unable to attend their follow-up visit. And even within that time frame, we found that in looking at the charts, we looked at phone calls to the clinic, and we found that 64% of the patients were calling the clinic during that period from when they were home till when they were readmitted, with questions around issues, still problems as for the same reason they were actually admitted in the hospital, or clarifying questions and inability to understand some of the instructions they had follow-up. There was a subset, 9 of the patients who were actually admitted onto non-Smilow units. So sometimes when we are in overflow, patients go to 6, 7, or other non-Smilow units. And we found that those patients, it's an area that can be worked on, had follow-up visits scheduled for their primary disease process, which could be a month or 2 out. And in looking at those patients discharged from other units, that visit was used as to be considered a follow-up, and they routinely were not scheduled for another visit to focus on the admission itself or why they were in the hospital. We also drilled down by palliative care referrals because as previously described, many of these patients were end of life and half of them died. So this shows here that out of the 55% of patients did not have a palliative care referral by their second admission, and 50% of the patients who died were never seen by palliative care. So again, we broke it down by section just to see if there was themes or areas to target, and it's pretty spread that there's an ability to utilize palliative care on both sections. And then looking at combining palliative care with hospice, the key takeaway here is that 30% of the patients who died were never seen by either palliative care or hospice. Then in looking at the sort of those last 3 to 6 months of life and what's happening, so all of these patients were on treatment, active treatment during this time. We looked at the chemotherapy during these dates, and what was pretty interesting is that 45% of the patients initiated a new treatment plan in the last 3 months of life. So these patients are spending a lot of the end of their life in the hospital getting treatment and then getting readmitted for symptoms related to the progression of that. So to switch gears a little, this next section talks about the patient interviews. What we wanted to see was the patient's perspective of what they knew about their disease, what they felt could have helped prevent their readmission, if anything, and any information that they think would have been helpful to the process. So again, we completed interviews on 43% of the patients, and that was during their readmission at their bedside that the interviews were completed. So we asked all the patients, did your cancer doctor discuss goals of care with you? 26% said no. And there's some comment, we have specific quotation comments from patients for some of these areas. When asked what they believe could have prevented them from coming back from the hospital, overall, these are some of the candid comments here on the screen, but the general consensus was better discharge planning, an inability to get the needed meds or supplies. So they were sent home with prescription. An example is Lovenox, and then it was either not cleared by their insurance or the pharmacy didn't have it, so they weren't able to pick it up, thus requiring calls to the clinic and coming back in. Or a sense that there was issues from the first time that were never fixed. One example is, a patient who was admitted for abdominal ascites and problems and was drained, but ultimately came back in 5 days later with the same problem. Then we asked, was there anything that we could have done differently? And again, some of the same comments, but also showing that better discharge planning would be helpful, and a feeling that they were being rushed out the door. So they might have been here for a month, but then on that last day or two, all this stuff is being thrown at them, and they're kind of feel like they're being pushed out the door. And tell me anything that was unclear or confusing. And again, you can see some of the comments, not scary, not knowing my diagnosis, couldn't get the medications. Again, they describe a feeling of confusion and being rushed, not understanding of what they needed to do to take care of themselves, or a lack of understanding about their disease or disease process were some of the themes that came out loud and clear. So some of the key findings from the work we did was 53 patients were admitted a total of 181 times over the study period, with a range of readmissions between 1 and 7. 68% of patients were admitted 3 or more times. 45% of patients were readmitted within 7 days. 17 patients, or 31%, had the same diagnosis the first and second readmission. 50% of the deceased patients died in the hospital, not under hospice. And of the deceased patients, 45% initiated a new treatment plan in the last 3 months of life. So, next steps. So this work has resulted in we are chartering 3 groups based on the results of what we feel could impact this, and the groups will all be co-led by a physician and a nurse leader. The first group is considered the follow-up visit. That will look at exploring the use of readmission risk scoring tools. It'll look at standardizing the follow-up phone call and developing a specific protocol for follow-up appointments and screening that will focus on the hospitalization that they just had to prevent the readmission. The second group is palliative care. This group has actually already kicked off, and they will look to develop standard criteria for initiating a palliative care consult and standardizing consults based on national guidelines. The final group is looking at optimizing care coordination and discharge planning. This group will be actually be managed by the ICG, the internal consultant group for the hospital, will be helping to run this project, and it will be looking at standardizing transitional care lines, appropriate placement of patients and resources on discharge, access for patient and family ability for self-care, assess, and then ensure that prescriptions, medication, supplies are available to the patient and that they're able to get them on discharge. I would like to acknowledge the team members for this group are listed here, and Dr. Edelson has been instrumental in helping move the groups forward. And Dawn Blake and Kristen Roach also were very helpful in completing the patient interviews and chart reviews during this, which was really tedious going through some of the charts. So that is overall the readmission project, and I'd be happy to take any questions, comments, thoughts.
So can you go back to your next steps? Just thinking this through off the cuff, how would you want to measure these initiatives going forward? What sort of things do you want to measure?
Readmission rate, ultimately.
Well, in terms of, agreed, ultimately, but in terms of the processes that you look at.
So we have charters for each of the groups, and they will be defining what some of those outcome metrics are. Palliative care would be like the number of consults, clearly for those patients, and some of the transitional rounds, it'll be a matter of looking at standardizing that. So we haven't come up with all of the outcome measures for each of the groups yet, but as they kick off, that's part of what they will be doing. Lisa is actually co-leading the palliative care with Dr. Probet. I don't know if you have any specific outcomes yet.
We've talked about looking at sure. So the 3 groups that came up as the high readmission populations, as well as the groups that had the higher rates of death, so lung, hematology, looking at their baseline rates of palliative care utilization, and then how we can impact or increase the utilization specifically for those groups, I think would be one target.
We will move on to Lisa's presentation and then take any further questions at the end.
Is this mine? No, that's mine. You can have it. Good afternoon, and thank you for the opportunity to share our work today. I'm going to be talking about a project that we implemented when I was in the role of oncology patient education specialist around engaging patients and caregivers in assessing chemotherapy education competency. Patient-centered communication is becoming increasingly important as we know that this now can affect outcomes. Patient-centered communication can be defined as healthcare that establishes a partnership among practitioners, patients, and their families to ensure that decisions respect patients' wants, needs, and preferences, and that patients have the education and support that they need to make decisions and participate in their own care. How well we provide this education and support can have a significant impact on outcomes. Suboptimal communication between clinicians, patients, and families can have significant negative consequences, including less trust in the healthcare team, medication errors, hospital readmissions, less commitment to the decisions that they make, and an increase in safety events. How do we know when we're communicating effectively? This is an area of increasing research, specifically under the umbrella of patient-centered outcomes. We provide patients with surveys from Press Ganey and the Hospital Consumer Assessment of Healthcare Providers and Systems, or HCAHPS. And here's a sample of questions that patients are asked that really try to get at how effective our communication is. The two bolded questions represent areas where we consistently fall below the target around communication about medications. While these tools and these surveys help guide our performance improvement efforts over time, they don't really provide us real-time feedback about how well we're doing. So in day-to-day practice, what tools can we use to assess how well we're communicating with patients? So TeachBack, I'm sure many of you have heard of, is an easy tool to assess if we're communicating effectively in the context of the clinical encounter. It's not a test of the patient, but is supposed to test how well we are delivering the message. It's a research-based health literacy intervention that promotes adherence, quality, and safety. It's not a test of the patient, but more a test of us. We know that our patients suffer from information overload. Nurses, advanced practice providers, and physicians present patients with tremendous amounts of information in an encounter. Often we expect that patients act on this information. We expect them to make decisions, we expect them to adhere to their medications, and we ask that they provide their own self-care and follow-up. So failure to check in on their understanding can lead to unintended outcomes.
Well, sometimes doctors make mistakes. Anna, you have to try twice as hard to fix them. Are you using your inhaler?
All the time. Go through one a week.
You sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
Jerk.
So, House provides us a really obvious example of how, if TeachBack was used in that initial encounter, it really would have prevented Anna from having to come back in. So that was an extra healthcare visit that was probably unnecessary. And I think that we all, as healthcare providers, make a lot of assumptions about what patients understand. However, the only way we really know is to ask them. So understanding that TeachBack is a really easy and effective tool, I really questioned, are we using TeachBack as nurses in Smilow? So I surveyed a sample of Smilow nurses, asking if they knew what TeachBack is. And you can see there that 83% of nurses did know what TeachBack is. However, only about 67% admitted that they use it regularly in their everyday practice. So I then went a step further and wanted to develop a competency evaluation to assess nurse utilization of TeachBack. So to provide some background, all nurses in Smilow who administer chemotherapy undergo an initial chemotherapy and biotherapy certification. And then annually, we do a competency reassessment where we focus on things like order verification, chemotherapy administration, responding to reactions, and patient education. These assessments are typically done in a simulation center using simulation mannequins with competency assessments performed by our oncology service line educators. For this exercise, rather than rely solely on our educators to assess competency, I really wanted to get the patient and family perspective. While there's many studies that use standardized actors or standardized patients, I felt that it would be more realistic and more meaningful to engage our patient and family advisory group in this exercise. So we recruited volunteers through our oncology PFACT. 13 advisors participated over 8 days. Each advisor participated in a 2-hour training session where we reviewed expectations, reviewed use of a standardized assessment tool, and discussed strategies for providing constructive feedback. Unlike standardized patients, our patient and family volunteers were asked not to act, but to respond naturally to each interaction. Each nurse was asked to spend 5 minutes providing focused education to one of these patient advisors on one of the following scenarios. The first 2 scenarios were selected because they're common encounters with patients, so vesicant administration or reviewing when to call instructions after a patient's completed their first cycle of chemotherapy. The third scenario was selected based on a safety event that actually happened in Smilow around dexamethasone administration, where a patient continued to take their dexamethasone beyond day 4 and ended up being hospitalized for adverse effects of steroids. So we really wanted to check and see how our nurses are educating around those specific medication instructions. Our nurses were notified in advance that they would be encountering real patients or family members in the exercise, and were given the opportunity to review reading materials in advance. At the end of the focused education, both the educator and the patient advisor gave staff verbal and written feedback about their performance. If the nurse did not use teach-back in the encounter, which was really a key goal, the educator actually role modeled that exercise in front of the nurse. We also asked the patient advisor to give the nurse tips on what they felt they did really well. And an example would be that our advisor would say, I really liked that you sat down next to me when we reviewed the material. That really conveyed caring and kindness. And second, what could they have done differently, or what could they have improved? And a specific example is, you told me to monitor my temperature. That's kind of general. It would have been more helpful if you told me exactly how often and when to check my temperature. So they walked away with very specific tips for improving their own skills. So we used a standardized evaluation tool where we looked at 6 specific domains related to patient education that you can see here. The first was professionalism. The second was performing a baseline assessment, organization of information, use of lay terminology, allowing time for questions, and that teach back or assessing for understanding. We then asked that the advisors rate their overall level of satisfaction with the encounter. In addition, we asked the patient and family volunteers to make notes of words they didn't understand, instructions that they felt were too general, or things or behaviors that they thought were very positive or helpful. You can see for each specific domain or behavior, we listed or came up with what the target behaviors were for each score. So the scores range from needs improvement to average or outstanding. And we did this in an effort to standardize the scoring across the volunteers. Over 270 nurses were assessed over 8 days. This represents over half of all Smilow nurses across the network and included pediatric oncology, but did not include radiation oncology or surgical oncology because those nurses are not chemotherapy certified. So the evaluation results were collated and analyzed and revealed 2 areas that really needed improvement, where about 30% of our staff fell in that category of needs improvement. And those 2 categories were performing a baseline assessment and implementation or use of teach-back. Staff performed very well or above average in all other categories. We then collated the oncology educator evaluation results, and they really mirrored the patient and family volunteer results and showed that those same 2 categories really shone through as far as needing improvement. However, our educators were a little bit more stringent and more staff fell into the needs improvement for those 2 categories. Patient advisors rated the overall level of satisfaction, and you can see here that for 86% of the encounters, they rated the encounter as above average, which is truly a reflection of the outstanding nursing care that we provide. And a very small number, 2%, fell in the needs improvement category, and that was a very small number of nurses. It was very important to me to get staff feedback. This was a new exercise, and I knew may cause some anxiety or intimidation, so I really wanted to know how staff perceived this. So a very small number of nurses did not rate the experience favorably, about 5 nurses in total. However, the majority really found value and felt that the exercise was useful in helping them improve their communication skills. And you can see a few of the nurses' comments here. I felt that the simulation was very helpful. I received feedback in regards to my education style, and I will certainly bring back this practice to my clinic. We also wanted to know how the patient and family volunteers felt about it in the end. And you can see here that their feedback was also very positive. They felt it was a valuable use of their time, and that by participating in this initiative, they made a significant contribution to the nurses' learning. And this is one of our advisor comments here. This training is an invaluable tool for the nursing staff. Overall, the nurses I encountered were well trained and very caring, and this was a very enriching experience for me. So to summarize the evaluation results, a patient advisor and professional educator evaluations were pretty congruent. And based on those evaluation summaries, those 2 areas of improvement were identified around the baseline assessment and teach back. And the 2 areas where we really did well and scored above average for the majority were around professionalism and organizing the information well. I debriefed with all of our volunteers at the end of the 8 days. We reviewed the evaluation data, and I got additional feedback from the group. And we really identified some themes and key takeaways. The first was that not all, but some of the information was presented in a way that felt rote or routine, and patients felt that they were getting lectured to instead of having a conversation, and that the information maybe wasn't personalized to them. So as adult learners, adults want to learn in the context of a conversation and not a lecture. So we heard that loud and clear, that they want information in a conversational style in a way that is really personalized to them and their life. The second was around vague instructions. So being specific is critical. So I used the example of temperature. Another example that came through several times was push fluids or increase hydration. Patients want to know how much and how often in a really specific way. The third was use of medical terminology, and though overall we scored pretty well in that category, we still at the end came up with a list of about 20 words that consistently came up that they felt were really unclear. So an example is prophylaxis. We use that word all the time, but patients don't know what that means. So we really have to simplify it as much as possible. And I think as professionals, we really struggle to do that. You know, we're used to talking to each other and wanting to sound professional and intelligent, but when we're talking to patients, we really have to make the information as simple as possible. And the fourth theme was really around inconsistent messages. So we heard, 270 nurses provide education, about a third did the when to call scenario, and we heard a variety of temperatures used in the instructions on when to call that you can see there, ranged from 100.3 to 100.1. So for me, that really identified an opportunity to ensure that our practice is standardized across the network and that all of our nurses are using the same information. So taking that information, we really wanted to take the key takeaways to guide global staff education. And we've already incorporated much of this feedback and information into our standard oncology education classes at the time of orientation and the time of initial chemotherapy education. And we're really hoping to do a similar exercise for those nurses that didn't get the opportunity to come through. So our radiation oncology staff, our surgical oncology nurses, and our nurses who are new to the institution. We also took the opportunity to ensure that our instructions are standardized in our after-visit summary, and we're piloting magnets in some of our clinical areas, again, to really standardize the message that patients are getting. So through this exercise, we were able to assess nurses' competency in specific patient education domains from both a professional and the patient and family perspective that really enables us to target future staff education based on common deficits. Patients and caregivers can really provide valuable insight into the effectiveness of our communication. I think we really would have missed the mark if we didn't include them and get that perspective. It provided a unique opportunity for staff to get feedback from patients on how they can improve their practice, and it illustrated to nurses the importance of teach-back. So a combination of both professional and patient evaluation really provides a more comprehensive assessment of staff skill, and in the future we can consider other applications for this. So in 2016, we instituted a novel format to assess nurse-patient education competency using live simulation with patient and family advisors. One, we were able to demonstrate that this is feasible. We had a lot of concerns about how long it would take, how it would be received, but I think that we definitely did it successfully in a reasonable amount of time. The format was well received by nurses, and the feedback from the patient and family was certainly positive. And it provided us a wealth of information about how our staff are doing and which areas we really need to target for future improvement. I'd like to thank our oncology nursing educators and our oncology patient and family advisors who really worked hard over many days to make this a successful initiative. Thank you.